So welcome for this session today, where we are hosting quite a number of colleagues joining. Our discussion will be focused on HIV, AIDS, and cancers, focusing on challenges and progress in addressing HIV, AIDS-associated malignancies. And so there are some few ground rules that I would love to share with us. Let's remain muted until you get a chance to speak, with the exception of the presenters once they get their cue. You can utilize the chat boxes, Q&A sessions to post any question, any comment. Drop also, identify yourself there and just share with us where you're, joining us through, which country, which facility. And then, of course, we are recording this session, and so the recordings will be available later once we are done. So allow me to introduce the agenda for this session. Of course, we have a didactic a presentation or lecture by Dr. Warren Phillips. Thereafter, we will, have a case presentation from Dr. Fred Okuku. And then one of our survivors here at Moi Teaching Referral Hospital, Ampat in Kenya, Eldoret, will share his experience of being diagnosed with Kaposi sarcoma and how he has lived through until he's now a peer navigator, helping other patients through care. And then finally, we will have a session for question and answer, and also we will share our comments thereafter. So I think Dr. Warren is on call, so allow me to introduce Dr. Warren. He will share his presentation. Yes. So Dr. Warren is a medical doctor. He's also an associate professor at the University of Washington and Fred Hutchinson Cancer Center in Seattle, Washington. Over the last 14 years, he has served as a medical director of the Uganda Cancer Institute, UCI, Fred Hutchinson Corporation in Kampala, Uganda, where he oversees the program research and training activities. He's also the director of faculty development for the collaboration and serves as the PI of faculty and NCI D43 training grant to support the development of early career investigators engaged in research on HIV-associated malignancies. Dr. Phillips conducts such research on infection-related cancers in sub-Saharan Africa with a focus on human papillomavirus, HIV/AIDS, virology, and the pathogenesis of Kaposi sarcoma. He also studies the impact of HIV and antiretroviral therapy, ART, on cancer incidence and outcomes, as well as the causes of infection in cancer patients in Uganda. Help me welcome Dr. Warren to share, and we appreciate your time, Dr. That's what we call in Kenya here. So welcome and proceed with your presentation. Thank you.
Great, thank you so much, and thanks for the invitation to speak. Are you hearing me okay?
Yes, loud and clear.
Okay.
Thank you.
Great, well then let me share my slides here. Okay, and hopefully you're seeing these all right as well. Whoops, I will. Again, as I said, thank you for the invitation to speak with this group. And an area that I believe the organizers were hoping to hear about, and all of you, is some of the work that's being done with an NIH clinical trials group called the AIDS Malignancy Consortium, which has really been focused on trying to advance research, particularly clinical trials, for the care of patients with HIV and cancer. And so wanted to share with you a little bit this morning about the work that the group is doing, and hopefully can be thinking together about how these kinds of efforts can help address the needs of the many patients that I think we all see in sub-Saharan Africa with HIV and cancer. And so just sort of from the start of the HIV epidemic, the connection with cancer was quite apparent. And this is an example of one of the early notices of in a newspaper of recognizing that there was something unusual happening, and it was the fact that Kaposi sarcoma was being seen in young men, in this case in New York and California, at a time where that was unusual, and people were wondering what was it about the situation that KS was being seen in these young men. And it turned out that that was really the heralding of the HIV epidemic, at least in the US and Europe, and certainly had already been occurring in sub-Saharan Africa. And here's a sign that's calling it the AIDS KS Foundation, just really highlighting from the very beginning, there was a recognition that HIV infection led to an increased risk of cancer. And so over time, this has been tracked carefully. And here's some data from Meredith Shields at the NCI looking at how cancers changed over time, especially after the introduction of antiretroviral therapy. And what this graph is showing are in the green lines, the classic AIDS-defining cancers, so Kaposi sarcoma, non-Hodgkin's lymphoma, cervical cancer, and the blue bars are other cancers that are not one of those three. And I think the important point is that while over time, some of the AIDS-defining cancers reduced as a proportion of the kinds of cancers we're seeing, there was an increase in other cancers among people living with HIV. And this was due to a lot of factors, but one of them was as people lived longer, they developed different cancers. And so you can see sort of in this 1995 period, again, this is US data, that was when really effective antiviral therapy was available. But as the time continues and Meredith and her colleagues have taken this data up to the present day, you'll see that there is, despite the antiretroviral therapy, a continued large number and increased risk of cancer among people living with HIV. And so one of the challenges has been that research on HIV and cancer has really historically been neglected. And there's a lack of high quality data on cancer and HIV. And traditionally, there has been people with HIV have been excluded from cancer clinical trials for various reasons, but one, a concern that many of the treatments might be unsafe for them. And hence it might be less likely that they will be prescribed cancer therapy. And certainly for those conducting trials, I think have sometimes avoided enrolling patients with HIV out of concern that it would complicate their understanding of the efficacy of the drug and perhaps how they analyze the data. So there really has been a growing and had been a growing disparity in the research among people with HIV and cancer. And while they have a higher incidence, right, a greater need and higher mortality, there's really been the least amount of focus on cancer research for people with HIV. And this is, again, highlighting what I think most people, anyone on this call would recognize, is that this is particularly true in sub-Saharan Africa, which is disproportionately affected by HIV, and hence also has some of the greatest burden of people living with HIV and cancer. So it's really a new challenge to address this need really globally. And so here's an example of data from Globocan. Many of you might be familiar with this World Health Organization data set that is highlighting, I'm showing you data from cancer registries in East Africa of the top cancers seen, and these include cervical cancer, breast, prostate, esophageal, colorectal, KS, ovary non-Hodgkin's, liver, and stomach are the ones that are listed. And although the the databases do not actually routinely collect data on HIV status of contributors to the registries. I think we could look at these and suggest that there probably is a high incidence of HIV driving several of these cancers, including cervical, esophageal, Kaposi sarcoma, NHL, and perhaps even liver or stomach. So as Raphael indicated, I work in Uganda along with, I think, others on this call, some of our colleagues, and we try to better understand what is the true burden of HIV infection at our institute, at the Uganda Cancer Institute. And we conducted a retrospective chart review to assess our entire patient population. And what this graph on the right is showing is the distribution of HIV in our population, with the green bars are those people with HIV, the blue bars are HIV negative, and the red bars are those that we did not have data on. And you can look for the, the high green bars on the left, cervical cancer, KS, non-Hodgkin's lymphoma. So we certainly have our traditional AIDS-defining malignancies. But when you start looking right across the graph, you'll recognize that really every cancer type has a significant portion of people with HIV infection. So, and that includes breast cancer, it includes prostate, liver, et cetera. So it really highlights the need to think about HIV, not just in our 3 AIDS-defining cancers, but really across a spectrum of disease for all of our cancer patients. And we estimated, based on these data, that 1 in 3 patients that is seen at our institute, at the Uganda Cancer Institute, has comorbid HIV infection. So it's really among this background of high need, high burden of HIV and cancer, as well as that disparity of a lack of good research and data to support better management of people with HIV and cancer, that led the NIH to found the AIDS malignancy group back in the 1990s. And here is a list of the strategic goals of the AMC, which really continue today. And that's to evaluate new treatments for the prevention approaches, and to establish better standards of care for malignancies and pre-malignancies in people with HIV, to contribute to scientific understanding of the pathobiology of cancers and pre-malignancies in people with HIV, to conduct research both domestically and in high disease burden areas internationally. Certainly that includes sub-Saharan Africa. And finally, to recruit and encourage new investigators to contribute to and participate in the AMC scientific agenda in order to foster the development of the next generation of healthcare professionals engaged in HIV malignancy research. So here again is a little information about the history and expansion of the AMC. So founded initially in 1995. And again, this was really in the era when still sort of early in the HIV epidemic, but a lot of recognition of need by that point. The group did expand internationally in 2008. So this was over a decade later that there was a recognition that there would be a benefit to look at this as a worldwide issue. And the initial sites in sub-Saharan Africa were selected and initiated in 2010. There was also an establishment of a large biorepository in sub-Saharan Africa in Cape Town. And then over sub-Saharan sites were selected in expanding the international footprint of the program. And so here is a overview of the current international sites of the AMC. There are 4 sites in Latin America, and those are highlighted on the left of the slide. And there are 6 sites in sub-Saharan Africa. And many of you may be affiliated with these sites, or certainly know colleagues at these sites, but these include the Uganda Cancer Institute in Uganda, the UNC Project Malawi in Malawi, Moi University in Kenya, the University of Zimbabwe in Harare, and then 2 sites in South Africa, one at Stellenbosch University and one at the at Wits in Johannesburg area. And so just to give a flavor of the kind of work that the AMC has done, there are 4 studies that have been completed. These include 2 studies focused on treatment for Kaposi sarcoma, both looking at chemotherapy as well as the timing of chemotherapy and ART for limited KS. There was a study for DLBCL, which was intended to look at CHOP versus an oral chemotherapy option, as well as studies focused on cervical cancer and radiotherapy. There are currently 3 studies that are ongoing. One is a study of nalfinavir for KS. This is a study actually that has just closed, but there is some follow-up of participants that's ongoing. An active study named 099 or numbered 099 called Covenant, which is a study looking at 9-valent HPV vaccine for reducing HSIL recurrence, as well as a study looking at pomalidomide as a treatment for Kaposi sarcoma. So this is, again, just an example of ongoing studies. There are several more in the pipeline focused on cervical cancer KS, and then hopefully soon another study focused on hemalignancies. So what have been some of the challenges and successes? I think one of the big challenges, and others on this call, I know Fred is on it, who's been very involved in the AMC, may have some additions they want to make, but really building capacity at sites to conduct clinical trials, I think, has been a big success. And so really working as a group to develop the protocols and implementation strategies for clinical trials at the sites, assessing pharmacy needs and augmenting training as needed, supporting drug acquisition, as well as training for chemotherapy nurses for administration of cancer-related drugs, as well as really detailed cancer response assessments and advanced event reporting, as well as capacity for data management, community engagement, and pathology capacity. And the pathology capacity I did want to mention, there is a large biorepository supported by the AMC, as well as the AIDS and Cancer Specimen Resource that is located at Stellenbosch University in Cape Town. And this is a biorepository for specimens that are collected as part of clinical trials. But through this ACSR, which hopefully folks have heard of, but if not, there's information about the ACSR on the websites. And these is a biorepository that you would have access to as an investigator and can apply to utilize resources and specimens for your research. So it's a terrific resource for those of you who may be interested in doing laboratory-based work on biospecimens. So another component of the AIDS Malignancy Consortium is career enhancement. And there's a specific program dedicated to supporting the development of the next generation of investigators interested in HIV-associated malignancies. And these awards provide 2 years of funding to support mentored research that is focused on HIVAM. And this work can be clinical, it can be translational or basic science. And to date, there's been 31 individuals that have received AMC fellowships, and many of these fellowships have been awarded to investigators from sub-Saharan Africa. So really, half of all of these are sub-Saharan African investigators. So this is, I think, a really great opportunity, particularly for those who are engaged at sites that have current AMC site established. So again, thinking of lessons learned, One of the challenges is we did have that study I mentioned, 068, which was a randomized trial of IV versus oral chemotherapy for diffuse large B-cell lymphoma. This was a fairly ambitious study and planned to enroll 90 patients, but it closed after 2 years after only able to enroll 7 patients. And so I think one of the lessons learned was making sure that the inclusion and exclusion criteria were appropriate. We were targeting the right patient populations, and really, I think, ensuring that the design of the study is appropriate for the patient populations that exist in sub-Saharan Africa, as well as, I think, several challenges related to the logistics of getting studies up and running, particularly some of the regulatory reviews. This is, again, one of the AMC's first studies attempted in sub-Saharan Africa, but through it, I think a lot of lessons learned that have now been applied to future studies. And there's actually a paper about this experience in the Journal of Global Oncology from 2020. There's also been success. Yes.
You should be winding up. Thank you.
Okay, sounds good. And there have also been successes, including the study 066, the treatment of advanced KS, which has now been showing that paclitaxel is superior to bleomycin and vincristine, and these have been incorporated into the NCCN harmonized guidelines for Kaposi sarcoma, which, again, many of you may use. And I think the current landscape is there's a need for ongoing clinical trials. Here's a paper again in JCO that is highlighting who is getting, what trials are being done and what some of the needs are for people living with HIV. There's still a gap and a disparity in the work that is including people with HIV and cancer trials. So why don't I leave there? This is just highlighting that there's a lot of future work in development with the AMC and the increased range of cancer, as well as an emphasis on quality of life. And so I encourage all of you to get more involved. And I think hopefully the future, there will be more sites added to the AMC. And so I think there's an opportunity for further engagement. So why don't I end there? Thank you very much. And I think we'll probably have time for questions at some point during the session.
Thank you so much, Dr. Warren. That was great presentation and great insights, and congratulations for the work you're doing. It was exciting to see also one of my mentors here, Dr. Nathan Zagala, feature prominently. And I'm glad you're doing great activity. So I encourage us to drop our questions or comments in the chat box, even as we proceed with the presentations, so that our presenters will have a look and later we'll have an open session to share. And so I want to invite Dr. Fred Okuku. Yes, you've heard him being introduced even in the presentation, as he's on the researcher in the Uganda Cancer Institute. So I think Dr. Fred should be here.
Yes, I'm on.
Yes.
I sent Charles my my PowerPoint. I hope you've seen it.
Great.
Great. Just upload it for me. Thank you.
Karibu daktari. Thank you.
And asante sana. So, just as a way of introduction, I'm Fred Okuku. I'm a medical oncologist at the UCI, involved in the MC100 currently. That's the clinical trial that Warren has just mentioned of pomalidomide. We have almost 5 patients now enrolled, and this is to highlight, really, I just wanted to highlight the challenges we have with this disease of Kaposi sarcoma. Many years after ART was introduced, we're still seeing some people come quite advanced. Next slide, please. So typically, we used to see almost 1,000 patients with Kaposi sarcoma every month. I mean, every year, but now these numbers are down. We don't see so many people, but the few that come are very, very sick. And this is an example of one of those. His name is SC, 32-year-old male peasant, referred from the ID ward. That's in the main hospital, Malago Hospital. And he already had a diagnosis of Kaposi sarcoma from a skin punch biopsy from the right upper arm just a month ago. He had difficulty in breathing and had these skin patches, which he's had for over 1 year. And he had been on ART for over a year. He's on the popular combination now is TLD that most patients receive. And he did report that he has been adherent to his treatment. His CD4 counts done while he was on this admission was 1,690. Please note that that value there, it's a very one would say this is, quite normal value, but we will query why people with high CD4s like this are still developing Kaposi sarcoma. His viral load was unknown at the time, so we didn't get hold of that. Next slide. These patches have worsened over the last year to involve the entire body. There was no history of blood in stool. While on this admission, he was evaluated for possible tuberculosis. His sputum was done. They did an X-ray, and they also did a urine lab, and none of those were suggestive that something was going on, although there was something on the X-ray that looked otherwise. He did undergo a protrap twice while on the ID ward, and he described the fluid from the lung as a whitish sort of pus. He also has a history of drug addiction. It's not very common to see this, but yes, we do have some people who are on cannabis and what they call Cuba and many other things. Next slide. So his physical exam, he was laboring, he had labored breathing, he had moderate pallor, no jaundice, but significantly had this lower limb swelling. There were no palpable lymph nodes. His ECOG was around about 2 at the time. His oral exam was had extensive Kaposi sarcoma, raised lesions. He also had extensive skin lesions, entire body. His musculoskeletal system, he had contractures round about the knees. He couldn't stretch those quite well. The lung, he had these crackles with reduced air entry on the left side. His blood pressure and the pulse seemingly normal. Next slide. His abdominal exam was really not significant. There was no evidence of ascites. And at that time, that was the evaluation of Kaposi sarcoma, T1 disease, his CD4 being above 1,000, the I becomes a 0, and the S with other comorbidities that he had had. These are some of the investigations, again, highlighting the gross effusion in the lung and some mid and lower zone nodules, most likely pointing towards PKS. His hemoglobin was on the lower side of 9 and had very low albumin, although the total protein was reported as normal. Next slide. He, as mentioned earlier, he had commenced some treatment with paclitaxel, and the user dose is at 100 milligrams per meter squared. He did about 6 cycles. in the last year and then got lost to follow-up around about April of this year. He had by then achieved some partial response. As you can see, he had extensive disease, and he had been suggested to be on 3 monthly reviews around about September of this year until November, when he returned, and he was in a very, I mean, he couldn't breathe, he was confused and had all this. So our team on the ward believe that what they are seeing in the lung is a chylothorax. It looks like pus, milk kind of thing, and they have so far drained about over 3 liters of fluid. Next slide. Yep, that was about it. That was the last slide. So he's a young man that we think is very sick right now, and with very significant amount of Kaposi sarcoma, as you as I've explained. And we think that his most likely thoracic duct must be damaged because of Kaposi sarcoma. And what we are having is continuous drainage on that side. He still has that chest tube in situ, and we don't know how far we are going to go with this, but we think that this is one young man who has complicated Kaposi sarcoma, possibly with a kick syndrome, possibly with many other complications. So briefly, this is a kind of case that we see. My question and discussion, I think, at some point is, why do we see a very high CD4 count? And yet we see Kaposi sarcoma. Are these CD4s functional? Are they false CD4s? Are they, and this is not uncommon to find young men with very high CD4s. Is there something causing these very high CD4s that are not functional? Thank you very much.
Yes, thank you, Dr. Fred, for that very brief, though very elaborate presentation of the case. I want us to just take a moment before we allow the last presenter just to, ask questions, share comments. And I want to recognize also the team from MTRH, led by Dr. Esther Freeman, who are also involved very heavily in supporting our patients who are diagnosed with KS. It started with what we call rapid case ascertainment, and they're now offering treatment and follow-up. So there are a lot of issues which are coming along with this case. So allow me to open the discussion. You can unmute and just share your experience, pose a question so that we see how best we can support our patients. Thank you very much. So far, I've not seen any question in the chat box. So you can just unmute yourself and proceed to ask a question or share a comment, please.
Hi, Koima. This is Esther Freeman. Thank you so much. What a great set of presentations. And I'm really looking forward to the presentation from our survivor after this. I had a question for Warren, actually. I saw that one of the upcoming trials is going to be on liposomal doxorubicin versus paclitaxel. I was just wondering if you could share a little bit about the status of that trial and where it's going to be happening.
Yeah, hi, Esther, and thanks for the question. I see that Matt Pineshab is in the audience, and Matt is one of the investigators leading that study. So I wanted maybe to give Matt an opportunity, but this is a study that is, the protocol is ready to go, and we're really focused now on an implementation, and this will be conducted in Sub-Saharan Africa. But Matt, do you want to comment on the study?
Sure. You're lucky. I was just kind of joining as I was like getting myself to work this morning. I'm in the
I just
US
saw your
right
name
now.
pop up.
Yeah, I'm in the US right now. You caught me before I got on my bike, actually. But we have largely gotten regulatory approval at most of the sites. And so I believe the plan is at MTRH and UCI, at KCH in Lilongwe, as well as Stellenbosch and in Zimbabwe. And the trainings and such are meant to start kind of early 2024, and then hopefully start enrolling patients in the first quarter or second quarter of 2024.
That's great. Thank you. I think this is a trial I've been very excited to hear about. So super pleased to hear that.
And just to comment, and that is going to be leading this as well, but includes also an economic analysis of the drugs. So I think there'll be a nice component to look at cost effectiveness as a component of this study, which we don't have in many of our studies, but hopefully we'll more in the future, which may be an important factor to consider in terms of the use of these drugs.
That's great. Thanks, Warren. We have, as you know, we did a cost effectiveness analysis for comparing standard of care BV to paclitaxel and liposomal doxorubicin, but definitely not in the sense of doing it in a clinical trial. So I think that's fantastic data that we'll be really looking forward to seeing.
Great, thanks. Any other comment, question? Because we are giving ourselves around 5 to 7 minutes before we allow our other presenter to proceed. Thank you. So if there is no another question or comment, I think we can allow Fred Matonye to just proceed to share his experience, and later we will also recap. Come back for some more questions and discussions around this. So Fred is one of the patients who are treated here in Moi Teaching Referral Hospital in Eldoret under AMBAT program, as I said earlier, rapid case ascertainment. Which was initially which was running here at MTRH. So he got his diagnosis here. He started his treatment here in MTRH and completed treatment and improved remarkably well. And at one point, when the program transited to what we call Kaposi Sarcoma Center of Excellence (KCE), there was need to have to engage navigators to also help other patients navigate through the systems, because we know for sure most patients interacting with our systems, hospital systems, is sometimes very difficult. I've had experiences where a patient can actually fail to get into one area of service and just give up. And the next time you call that patient, they are at home. So Fred joined KCE as a peer navigator. He has been doing tremendous work in supporting patients in the program, not only Kaposi sarcoma diagnosed patients, but other patients who have different kinds of cancers here at Chandaria Cancer Center, Moi Teaching Referral Hospital. So allow me to invite Fred to share his lived experience. Thank you. Fred, you can join.
Thank you, Mr. Koima, for inviting me. Okay, my name is Frederick Shiravika. I'm a Kaposi sarcoma survivor. Okay, my left leg started swelling without any pain. I went to the hospital, but I was told it was because I am a driver and I sit for long. So I was just advised to raise my leg when I get to rest. The problem continued, and I developed a lesion on the foot. So I pricked it since I thought it was just a growth. From there, things became worse and it became a wound. It started discharging fluid I went to different facilities to for help, but the wound was just dry, was not drying. So one day I visited Coast General Hospital in Mombasa. Here they removed my dead tissue. It took a biopsy, but they never gave me results. From this point, I was so sick that I could not do anything. Even using the toilet was a problem. But I thank my wife since she was there to help me. Oh, it took me 6 years without knowing the problem was. I used traditional medicine, but it did not help. So I thought this was a witchcraft. All this time, I did not know my HIV status, and no one had advised me to be tested. I stopped working because of the disease. I later came home from Mombasa and visited a health center. They tested me on HIV, which turned out positive. I was put on ARVs, but threw them away since I was in denial of the diagnosis. 1 year later, the disease was worsening and I decided to visit Mosbridge Amber's facility, who restarted me on ARVs. By this time, I had accepted my status and was ready to start treatment. Then referred me to Chandaria Cancer Center, MTRH, where biopsy was done by the KS study team. By this time, I was on crutches and sometimes on a wheelchair. Results came out confirming that I had KS. From here, the challenges was starting treatment because I did not have an insurance card. My family could not help since I was the breadwinner. Friends had ran away from me and even blocked my number. I was in a lot of pain, but my parents told me not to give up. One day, a friend of mine came to visit and registered me with the NHIF. I waited for maturity, then I received chemotherapy treatment. When on chemotherapy, I used transport reimbursement from the KS study to top up my NHIF. After the first chemotherapy, I slept peacefully, and then, unlike the previous 6 years. But the third chemotherapy, the wound was drying and I stopped using crutches. This motivated me to complete my treatment. After chemotherapy, I was feeling strong, energetic. I could ride a bike and started business that could support my family. 2 years later, I joined KS program as a peer navigator. My experience as navigation as a peer navigator, I'm glad to encourage and motivate patients that cancer is not a death sentence and there is a light at the end of the tunnel with a treatment. In my daily routine, I meet patients after the doctor has disclosed KS diagnosis to them. Just before they start their treatment, I begin with sharing my experience, showing them KS diagnosis and treatment education videos. After sharing my KS experience and how I overcame the challenges, some patients still do not believe that I am a cancer survivor and HIV positive. Thank God for KS educational videos where I'm featured. This makes them believe, look forward to start chemotherapy and hope for the survival. Some KS patients who are HIV positive do not take their ARVs well, and I advise them on adherence. For those struggling with disclosure, I go to an extent of showing them my ARVs. I also share on how I came to accept my HIV diagnosis and found it easy to disclose. Some patients come with mentality of witchcraft and believe in traditional medicine more than chemotherapy. But after my experience sharing with them about traditional medicine that even led to the worsening of my disease, it has helped them to chemotherapy adherence since they no longer believe in witchcraft. Thanks to Kaposi Sarcoma Center of Excellence for introducing navigation program. This has allowed me to save some lives. I have a number of patients who have made it through treatment and back normal lives through my encouragement. This is one patient who had given up together with his family and had refused to start chemo. He had lost his job and friends had run away from him since he was a burden. After sharing my experience, the patient agreed to start chemotherapy. He has now completed chemotherapy and is doing so well. Gone back to work, friends who had run away are now back. He can do his normal duties. I count this a success. I thank my PIs for giving me an opportunity to share my story with patients struggling with both AS and HIV. It puts a smile on my face and gives me a reason to wake every morning just to meet my patients. Lastly, I thank the ECHO team through Dr. Koima for this special invite. Just to mention that Koima is the person that did my biopsy, linked me to treatment and encouraged me that when I had lost hope. Thank you and may God bless you.
Yeah, thank you so much, Fred. I think I would invite participants just to open your videos and let's give a clap, for this amazing young man. If you're able to open your video, just clap for him. Yes. Yeah. We celebrate you, Fred. As you say, we saw you when I could not even recognize you myself. It's you who came later and said, I am the Fred. Because this disease is so devastating. And I know most of you have had experience. I also want to give a special thanks to my colleagues and my seniors at Moi Teaching Referral Hospital.
Koima, we lost you for a minute.
Yeah, so I was saying, colleagues in MTRH have really done a tremendous job, led by Dr. Kuzagala, Esther, Ellen in Uganda, Akre in Uganda. We have amazing also colleagues, Linda, Celestine, Job, formerly Erastus, and also our colleague, Cole Emily, is also one of the navigators in the same course. So I would love to open this up for us to really share. Fred has really given us all the experience that most of our patients go through, starting from the community to the, tertiary institutions. And he has spoken to issues about suspicion index among clinicians in the peripheral facilities, issues about counseling, you know, and look at the 6 years he has, you know, gone with a lot of trouble. Issues of being a breadwinner, losing, you know, the what the family can feed, you know, alternate medicine, medical attention, use of apple, witchcraft, and also some element of spiritualist. People are saying it's only God who can heal you, though it is true, but it's also God who can lead people to the right place to be helped. And the whole issue of navigation. So I just invite all of us to speak to this, as also you asked questions in the previous presentations, you know, and I know we have great warriors even in this meeting this evening. So please, you're welcome to share your experience, share your thoughts, your comments, and where you are in terms of supporting patients to access care timely, and even issues of financing is so huge. Remember, he was diagnosed here and he left because of ability to, you know, pay for chemotherapy, and waited until what you call the National Hospital Insurance, National Health Insurance Fund, which is a Kenyan government funded insurance. It takes like 2 months to mature. So imagine a patient being diagnosed, enrolled to NHIF, and wait for 2 months to access care. So those are the challenges we're experiencing across probably the globe. So kindly just unmute and share your experience. Thank you so much. And apologies for that emotional episode. Sorry for that. It happens.
I just wanted to open by saying a huge thank you to Fred. He's just been an incredible supporter to our patients. And when we started up the patient navigation program, we had this idea that a survivor would be the best person to be able to help our patients, as opposed to someone who had not experienced the disease. And Fred is our first peer navigator, and the whole program is basically built around him, and he's just done such an outstanding job. And to see him work with the patients, and to see how much they believe him much more than any of our physicians sometimes, right, because he's really lived it, is just so powerful. So Fred, I just wanted to say thank you for sharing your story with all of us, and for the incredible hard work you're doing on behalf of the whole team. And we created this video that Fred's featured in, that he mentioned, and even his father is in the video. And I think just your willingness to share your story, Fred, has changed so many lives. So I just wanted to say thank you on behalf of our team.
Thank you, Dr. Esther.
Yeah, thank you, Esther. You sharing, I just go on, just share your thoughts and your experience. You can do things. Thank you. Allow me to just ambush Sydney. Sydney is one of the committee member for this ECHO program, 2023-2024, and he's such an incredible person in terms of soliciting funds for, especially in childhood cancers, and we have cares in children. So I think, Sydney, you can, if you are able to say something, you can unmute and just speak to health financing and how it impacts care.
Thank you, Dr. Raphael. Number one, I just want to commend Fred for sharing his story. At the end of the day, as you said, Esther, the patient is using a patient is the best way of reaching out to other people, because it's easier to talk to someone who's gone through something similar to you, and it's easier for someone who's gone through it to be able to walk you through that journey. In terms of health financing, I know in a lot of the low and middle income countries like Kenya, health finance is a big issue, and just getting access to treatment is a huge issue, which is why my organization, Hope for Cancer Kids, raises funds to support these children by paying for their National Health Insurance Fund premium so they can access treatment. We are also trying to reduce the abandonment rate, because you find that even though they have access to treatment, and I'm sure it's the case cuts across all low and middle income countries, there's the issue of transport, there's the issue of accommodation, there's the issue of the limits to the co-pays as that come with the health financing. So even if you're able to get the insurance, there are still things that you have to pay out of pocket. And that's one of the biggest issues that leads to treatment abandonment. For example, a lot of the children that travel 400-500 kilometers to access treatment, and they come to Nairobi and they have nobody. They don't know anyone in Nairobi. They don't know where they're going to stay, what they're going to eat. So they end up, sleeping in hospital corridors. And I think the issue of health financing is one that needs to be tackled from all angles. It's not a civil society thing. It's not an issue for the nurses or the medics or the friends or the family. It's something that needs to be tackled holistically. And the more we start having these conversations, the more we'll get closer to an ideal situation. I know there's a lot of work that needs to be done and a lot of systems and processes, but health financing still remains one of the hugest gaps in accessing treatment in Kenya and in a lot of other countries. I think that's where I would leave it, Dr. Raphael.
Thanks, Sydney, for just bringing it out clearly. Dr. Fred, I think give us Uganda experience in terms of issues of navigation, issues of early suspicion index among clinicians in the peripheral facilities, issues of follow-up, which is also a big thing. Just speak to it from Uganda perspective. Dr. Fred Okuku? John, I think Fred is not.
Yes,
oh, yeah.
I am on. Hello, I seem to have missed a question.
Sorry, so just a recap. Fred, if you have been following, the issues of early suspicion index among periphery clinicians, issues of follow-up, patient navigation, which has come out, as major areas to be focused, and also financing, as just Sydney has put it. So how does it look like in Uganda?
So UCI is the main provider of cancer treatment. And it has one other peripheral center apart from UCI in Kampala, and that's in Barara. And there are plans to open other centers. Generally, our loss to follow-up rate is about 30%. That is based on previous studies. I believe that probably that may have changed because there have been so many efforts. The chemotherapy here is free of charge, and that's one motivation for patients to come. But I see Dr. Kavuche on here. He had a program of communication where patients could call back, and then there would be some follow-up to call patients who are not coming for their reviews. That program was initiated, but it's not running. So we still do have issues, but one of the main factors here is people are poor. They lack transport to come back. Even though the treatment is free of charge, we have a big loss to follow-up. The other challenge we have is a lack of information. When patients improve, they think the cancer is completely gone and they don't come up back for review. So UCI has started a program where they give some information to the patient. There's a chart they give you at the beginning when you open a file with information on your appointments, on your type of cancer, and what kind of treatment you're likely to get, and who your doctor will be, and how the follow-up will be. And that has improved those issues of loss to follow-up. But we still have a big, big challenge.
Thank you. I'm seeing Dr. John Black and is up. You can share your.
Yes, thanks for a very great session, getting from the different stakeholders. I raised this because I wanted to ask something about health economics evaluation, but I'm going to go to that. First, I want to speak a bit about the program that Dr. Cook has mentioned. We indeed set up a hospital call center that is automated, where people would call in a self-service manner, and they can listen to information. Information is power in care for cancer patients, but for really all health care. And indeed, we learned a lot in terms of what we think patients should hear versus what they want to hear. For example, we, from a clinician perspective, we want to talk about toxicity, and we talk about the difficult ones, neutropenic sepsis, for example, something that the patient doesn't actually worry much about because they don't really understand it. The thing that they understand is their skin color changing because they see that, or the hair falling off. And if we don't speak to that, then we haven't really spoken to their issues, so we haven't really communicated. We also noticed that patients, when someone is diagnosed with cancer or HIV, even when you counsel them, at that moment, they're really distressed and they're not even listening to what you're saying, and they need to get information over and over. I remember we had a person who was using this call center who had called in. So we were trying to evaluate it, and we surveyed people who were the most frequent callers using the system. And this gentleman who was actually at the UCI campus getting treatment was one of the most frequent callers, and we asked him, why are you calling the system when you're actually on campus? And he said, well, if I was to speak to a nurse and ask them the same question 3 times, they would snap and shout at me. But with this automated system, I can call as many times as I can, and I can listen over and over if I didn't understand, or if I forgot, or if I need to, speak with someone else. But there are all these different initiatives, and we've done this also in mental health to support patients. The UCI also has a navigation program. I think some of you know about that, where there's physical people doing this. I think it doesn't have a lot of patients, and I think that might be a limitation, because having expert patients like Frederick himself is something that is always highlighted as very helpful. We've seen this also in a setup that we've done for mental health, where people call in, and in that setup we have at Butabika National Mental Hospital, we have peer support workers. We have people who themselves are recovering from mental illnesses, and they help to answer questions on the phone via the call center system, and that is very helpful. But there's so many challenges, as Dr. Okuko has mentioned, as everyone else has mentioned. And so the question I wanted to ask, to put out maybe to Warren, but also to you, Dr. Okuko, and everyone else involved in research and implementation, is how do we get funding agencies and governments to invest? Because some of these things, for example, transportation or food, are not considered as critical. When we are designing research studies, we look at them last. We first try to look at the biology, and we understand the disease, and we understand the drugs. But there's been a lot of drugs, and still we are not effective in controlling the disease. People get lost follow-up, people don't adhere, or people don't come in time to get these drugs, and so the outcomes are not as good. And I want to sort of drop a parallel to what I've seen in HIV programs, where at first it was ART, and then there was a bit of social support, and now you see also nutrition coming in, because even if you give ART and you don't support with nutrition, the ART doesn't really, you face problems in achieving your goals. So, for example, Warren, is the AMC looking into these social aspects and trying to do studies on those, and getting evidence that can go to governments and funding agencies and saying, look, it's not only giving chemotherapy, it's also these other things. It's also transport, it's also counseling, it is the psychosocial support. If you could speak to that, Warren, and maybe Dr. Okuko, that would be helpful. Thanks.
Yeah, thanks, John Black. I think you raised a lot of important issues. And how do you translate and influence, particularly governments and, as you said, funding agencies to bring bring funds to areas that are needed. And so, and I do think at least one strategy and something that research can do is to provide the data to demonstrate efficacy and some approaches, to highlight need, and to help prioritize these areas for ministries of health and other government agencies. So I think the general idea of, yes, let's help the promote funds by presenting data and presenting evidence. And so one area that I think specifically for the AMC is an increasing recognition that quality of life is an important endpoint and patient-reported outcomes in all of our studies. And I think this is obviously not just the AMC that is trying to increase the patient-reported outcomes and the voice of the participant as a very important factor. And so there's several quality of life instruments that are well validated for use in many different countries. Particularly in sub-Saharan Africa, there's a tool called Promise, which is being used increasingly, and I think we're all getting more experience with it. But it's one way to at least highlight quality of life as an important outcome, and these tools look at not just one overall measure of quality of life, but also specific domains. And so I think that may be one way to highlight some of the areas that you're raising, John Black, that are not often included as quote endpoints in studies. You know, how does transportation affect things? How does nutrition impact? Although I do think there are studies and have been that look at nutrition, and that's an important area. I would say this is another good example too of getting people engaged who have interest in these areas, perhaps some expertise, to conduct the studies, to do this work, so that data is available to ministries to say, hey, we need to give people a food basket if they're going to have effective ART, and to demonstrate that need. But I'll open up to others who have a lot of experience too, Fred and other people on the panel.
Yeah, I think it's very interesting what John Black has brought out. My own experience in the clinic is I started asking patients about their sexual challenges while on chemotherapy. And it opened a whole new area that we are now thinking of doing some research on. Apparently in Africa, it's taboo not to talk about sexual issues. So many patients suffer quietly, or we started asking men about their sexual function and whether they were able to function normally, and women about their experience while on chemotherapy. And we got very interesting answers. You know, some men said, you know, since my wife got cancer, it's no longer possible even to have any time with her. And they thought that is what it's supposed to be while you're on chemotherapy. So it's like, that's not even, you shouldn't even talk about it. And they were having challenges quietly there. There are some women who were reporting that their husbands are not coming back home because they now have cancer. And we also had reports of separations and all these kind of problems because of the cancer treatment. So it's a very interesting point that you brought out. We never focus on the social issues, but they could affect why patients are not coming. If the man feels that the lady is denying him, he may fail to give the transport money to bring them to hospital. So very interesting issues that we need to, look at.
Thank you for that question. It's a great question. It's something that bothers us in our practice, and that's a good one. So I just want to invite Professor Hans, if he is able to share with us from Namibia. Prof, if it's okay.
Hello, can you hear me?
Yes, Prof.
Yeah, Actually, I even just joined you from the University of Namibia. Actually, what you are saying, we are also experiencing that issue of male supporting maybe their wives or their partner when they're having the cancer. And we are struggling with that because people, they don't talk about openly sexual issues, even to a stranger person. But actually also in Namibia, we are having a big hospital in the capital city where it is serving, we are having the hospital for children's, and we are also having the children for the, hello, can you hear me?
Yeah, sorry, proceed. Prof.
Yes, yeah, actually that's what I wanted also to share with you.
Thank you so much. I've also seen the representation from Zimbabwe. I don't know if somebody can unmute and just share what it looks like from Zimbabwe. Meanwhile, Dr. Sekil, I think you are in the call. Ethiopia, any comments? Yeah, Manju, Florence, you can proceed. Thank you. Thank you, Florence.
Thank you so much for the opportunity. I just want to chip in to say that when you look at cancers, especially for those living with HIV, it's really a great burden, just like we saw in the presentations and from the case studies and even from the experience that our brother Fred shared with us this afternoon or evening. It's really challenging in African countries. But when you go to the different African countries, you see that the cases are not the same. For example, Prof just spoke for Namibia, where we have the central hospital in Windhoek, where I think almost all their treatment, I can say, is for free. But when you get to listen to Fred, you realize that Fred had to pay for treatment and everything. And when you look at his case, at least he had somebody who supported him to pay maybe for health insurance where they could support him, and then he got the chemotherapy from there. When you look at a case, for example, of Cameroon, you see that it's completely different because we do not have medical aid. We don't have such insurances that take care of cancers. So patients have to pay everything out of pocket. And you see, thank God that with the PEPFAR project, the people living with HIV, they have free treatment and they can have other things for their HIV free. But when it comes to cancer, they still have to suffer and have to pay everything from out of pocket. So you will still see many people who are willing to maybe undergo a chemotherapy, but they will start and they will not finish because they are not able to pay. So I think that financing is still one of those problems and those issues that we have in some of the African countries that we really, really need to see how to address this, because if we really desire people to actually get treated or even have screening so that we can diagnose early for those cancers that are able to be screened and diagnosed early, you see that it will help us, and we are going to get, we are going to have a different narrative. We are going to talk differently and not coming back to say the same thing over and over every year. So I think that we really need to look at some of these situations, see what is working in other African countries. For example, what is working in Namibia? How can we implement it in other countries? What is working in Kenya? How can we implement it? So I think as ECHO, as the African ECHO, we can actually look at some of these, share the best practices and see how to pick from there and see how we can try to help our patients. It's true, we want the patients to be advocates. They're able to talk, they're able to encourage many others, but there are still some things that are hindering these patients from going in completely. Because it is not just accepting your situation. Many finally accept their diagnosis, because when somebody is seeing that I'm going to die, they are ready to and willing to accept anything in the name of treatment. So you see some of them still going back to traditional practitioners simply because they are not able to pay for their chemotherapy and many other things. So I think we really need to look at this again. Thank you so much.
Thank you, Florence. And you've summarized the 3 objectives of Project ECHO in your contribution.
Sorry, I wanted also maybe to share with
Yes,
you a little bit. We are having a worrisome with a number of cases of cancer among children, because it's become a worrisome in our country. I don't know what are the mechanisms in place to, we really need to come up with some research on this.
Thank you for that. I saw Erin. Thank you. Erin, I think I saw you making a comment, but you can share your contribution in the humanitarian space. I know you're doing a lot of work in the supporting a lot of people yes, Erin.
Hi, everyone. Nice to meet you. I am based in Kenya, but I was just really curious about that tool called Promise. Trying to identify how to help this, clinicians measure patient-reported outcomes. So yeah, I think it'll be helpful. Most of my focus is in palliative care, and oftentimes we end up with oncology patients in this region. So yeah, I've come across ESAS, which is I think out of Canada. But then, of course, the palliative care outcome scale, we have an adapted version in Africa through APCA. And I think it is a good scale. It's just difficult to analyze because when you analyze it, you do have to adjust based on some of it's a scale out of 5. And for some of the questions, the ideal outcome is a high number. And then for some of them, the ideal outcome is a lower number. So it's a bit confusing to use it on the ground. So I was just curious about this tool, but thank you for the links and I'll take a look at it.
Thank you, Erin. So I think we have some 3 minutes before we hand over to the Secretariat. I will just give somebody who wants to make a quick contribution, quick comment. Yes. So if there is no any other contribution comment, allow me to sincerely thank you for finding time to join these most amazing presentations from our, eminent panelists. I want to thank so much Dr. Warren for finding time and putting that resource together and just sharing with us what MCR is doing. And we have seen great developments. Even the ambition of opening more sites for the same, we encourage that. And Dr. Fred Ukuku, I mean, real scenarios in our space. Thank you so much for sharing that case, and we hope we have learned from that case and really strengthen on especially issues of early suspicion and just patient navigation and facilitating patients well to get care. Fred, our peer navigator and also the warrior, we are so glad to have, for you to have shared a very comprehensive story. Peer and encouragement to every patient you meet, because apart from just the, conventional medicine, holistic care is what is at play. Just encouraging people to pull through, and we have seen tremendous work you have worked. And so it has been great time just moderating this session. Looking forward to seeing you again and moderating another future session. I don't know if our chair, Africa ECHO, has a steering committee comprising of 16 members drawn from different countries. And our chair is Benda Kithaka. I don't know whether she is in the call. Benda, are you in the call?
She had an apology.
Oh, perfect.
Yeah.
So she is our chair. I would have given her some few, a minute just to make a remark. Otherwise, I want to hand over to our ECHO Secretariat who have been facilitating this ECHO program. Giles, we thank you so much. You can pick up from there. Thank you and God bless.
So thank you so much. I think mine is to just echo what Dr. Alafari is saying. We are so grateful to our speakers for today, Dr. Wallen, Dr. Fred, and our cancer warrior, Frederick. So we are so grateful that you are able to share your knowledge and experiences with us. And also Dr. Alafari, thank you so much for coordinating this session. We are very grateful. So we are going to be sharing the recording and some resources like what has been posted on the chat. So please look out for that. We normally share through Basecamp. And if you're not on Basecamp, you can always reach out and we are going to add you to our mailing list. So our next session will be held in January 18th. For those who are new to this platform, we normally meet on a monthly basis. So our next session will be on January 18th, which is basically the third Thursday of every month. So we are going to be sharing the agenda in the coming weeks, maybe early January, and we look forward to continue learning. So thank you so much from the Africa Cancer Echo Hub. We wish you all the best and happy holidays. Thank you.
Yes, bye everyone. Thank you.
Bye.
Bye-bye.
Thank you.
Thank you.
Bye.
Bye.